up, we're talking about sleep. So we have Dr. Amanda Turget from MGH here to talk about sleep. She is part of our MGH clinic that sees Duchenne kids as well as other chromosomal anomalies. So I'll let Dr. Amanda Turget take it away.
Hi guys, I hope you guys are having a good day. I'm gonna try to share my screen here. Just give me 1 second here.
We can help you walk through, Amanda. If you look at the bottom center of your screen, you should see a little green button that says share.
I saw that. I was trying to make sure I could still click through my slides because my other.
Oh, okay. Wonderful.
All right, so I'm going to do this. All right, can you all see that?
We can, if you want to put that into presentation mode then. Yep, so at the bottom left there you go. There
we go.
Perfect. Yep, looks great.
Okay. I'm going to guess that most of you are all here because you've missed a few nights of sleep. So I'm going to talk about sleep and neurogenetic syndromes. I see a lot of kids with duplication 15q, and I also see Angelman syndrome children in addition to other neurogenetic disorders. So learning objectives this time is, why is sleep important? We'll discuss that and how that might affect your child. Just some common sleep problems that we see in the neurogenetic disorders, and then managing the sleep problems in neurogenetic disorders. So why is sleep important? As you can see, this is Maslow's hierarchy of needs, but sleep is kind of the bedrock of everything, along with food and water and those kinds of things. But without sleep, it's very difficult to function. So how does that present in some of our kiddos with neurogenetic disorders? So it can cause daytime fatigue and tiredness, and this might present as falling asleep at inopportune times, such as in school, daytime napping, when the nap times are not appropriate for kids of that age, and just kind of overall fatigue throughout the day, lack of attention and wanting to do things. Can also cause behavioral difficulties. So some kids will see hyperactivity, but most of the kids will see them be kind of defiant and aggressive if they're tired, a little oppositional, and just irritable and impulsive. It can also slow down their physical development. So what does that mean? So it decreases brain function. And we all know that our brains are made of a lot of neurons. And so it decreases that neuron function, which is what we need to function throughout the day. And it can affect gene activation and expression, and it also decreases your ability to repair your brain from stress responses and things like that. So how this might present in one of our kiddos is physically is they'll have difficulty with occupational therapy or physical therapy, which a lot of our kiddos are involved in, and just overall difficulty functioning throughout the day. It can also slow down academic processes. And so sleep is where we commit all the memories that we've learned, or the things we've learned during the day, to memory. And so when we sleep, it's putting all those things we learned in our brain and helping them stick there. And if we aren't sleeping, obviously those things we have learned are not being committed to memory. It can make it very difficult to organize our thoughts, difficult to pay attention during school, and just, again, difficulty getting through our day. And then it can also complicate medical comorbidities. So a lot of our Dup15 kids will have seizures. It can decrease the seizure threshold. And because your gut is so neurologically tied to your brain, which if not sleeping is not rested, it can also increase your constipation and your likelihood for reflux. So sleep practices. So what are we going to do about that? We're going to have a good sleep environment. Some kids may require a covered bed in order to help keep them safe. I also have recommended to some parents that they make the room basically a giant bed. They put the mattress on the floor, take anything off the walls that is unsafe, make sure they can't pull over their dressers and things like that, and put a gate on the door if you're comfortable with that. And that gives them just a big space that is theirs where they can sleep and make it their space. The other things that we can do are make sure that their environment is quiet, dark, and cool. So some kiddos really like night lights, which that can be an issue sometimes. They can interfere with your release of melatonin and things like that. So we might need to get rid of night lights, or some people leave the hallway light on. That might need to be shut off. And then, making sure that their space, some of our kids have sensory issues. So making sure that their bed is a comfortable space for them and that they enjoy that space. We want the bedroom to be a happy environment, a good environment where they sleep. And so that brings me kind of my next point. The bedroom should be only for sleep. It shouldn't be for sitting and reading or timeouts or anything. The bed is for sleep and sleep only, and we want that to be a very calming environment that is good for any kids that have sensory issues. And then the bedtime routine. So bedtime routine should be short, 20 to 45 minutes. I prefer 20 minutes. And it should involve 3 to 4 activities every night. And it should be the same day to day, week to weekend, just very consistent. Kiddos like consistency. And it should be very specific and predictable. I often recommend to parents that they put up a schedule of bedtime events using pictures to identify what they're going to do. If it's brushing their teeth first and then they put on their pajamas and then we read a bedtime story. I also recommend that you do the items that they like to do last. So it's kind of helps them get through the most difficult things that they don't like to do. Some kiddos don't like to brush their teeth, so I'd start with that. Some of our kiddos really love bath time. So if that's part of the bedtime routine, we start with brushing our teeth, and before we can take a bath, we have to brush our teeth and just make sure to really, kind of enforce that and make it a positive experience rather than a negative experience. And then reducing negative nighttime behaviors. Like I said, the goal is to promote the positive nighttime behaviors and kind of ignore the negative ones. So if they're doing things that you don't want, this is easier said than done, I realize that. But if they're doing, something that you don't want them to do, you're going to kind of keep moving on to the next thing and move them through that if you can. As I said, I know that that's easier said than done. So I'm going to kind of walk you through what I do typically in a patient appointment, starting with, where do we start when I see a patient who can't sleep? So the first thing I do is rule out medical complications, right? So a lot of our kids have reflux, which, so some kiddos, even if they might be fine right before bed when they lay down, it can take a couple hours because that acid will kind of come up while they're laying horizontally. So they'll often wake up and be irritable, or oftentimes have difficulty falling asleep because they don't want to fall asleep. So that's one thing I check if we have a lot of trouble falling asleep. The other thing is constipation. This is a big thing. I think sometimes they don't realize kids are just really irritable, and if they're uncomfortable, they don't want to sleep. It's difficult for them to kind of lay horizontally as well in that instance when they're constipated. And then I start with a sleep schedule because I feel sleep schedule is important. You want the sleep schedule to be good before you start medication, because otherwise the medications are just a band-aid for something else that needs fixed. So how do we work on sleep schedule? So first off, we're going to determine the appropriate time in bed for your child. You're going to make sure their bedtime routine is consistent. And then you're going to enforce that bedtime 7 days per week. So on the weekends, I know that's difficult. Sometimes people like to sleep in, but what can happen if we're letting them go to bed later on a Friday or Saturday night and get up later on Saturday or Sunday morning is then when their pressure to sleep is not strong enough. So when they go to bed on a Sunday night, they're not as tired because they have slept in later, so their pressure to sleep is not strong enough to make them want to fall asleep. And we'll talk a little bit more about that coming up in a couple slides. So for our little infants, you want to put them down drowsy but awake, and then other kids, if they call or cry out, you're going to not respond immediately. So there's kind of two options when they cry. You can let them cry it out. Some parents are very against this, but there are studies that show that children typically have different cries for whether they're upset or in pain or things like that. So if they're just crying to have you come into their room and get them, you'll typically know the difference. Other studies also show there is no difficulty with attachment or anything like that by letting a child cry it out. That being said, I don't sleep train until kids are at least 4 months of age. And so I don't think crying it out is an effective method until they're at least 4, which is the point at which they can sleep through the night without eating. The other thing you can do is kind of graduated or gradual extinction. So you can go in and check in on them. You want to make this absolutely an unfun experience. So you're going to go in, say, mommy's here, it's time to go to bed, and you're going to leave. You don't want them to think that you're having a party in the room next door. You want them to, it's no fun. They should go to bed. It's a very strict thing. And you do that, and you kind of gradually decrease that, the time that you're in there. So you might go in at 5 minutes, and check on them. And then you're going to decrease the time as it goes over. As far as the crying it out goes, if you decide to do that method, I always recommend that parents, it's really tough the first night, and usually by about 3 nights, they've kind of figured it out. By night 3, they've usually figured it out, and then they're going to test you in about 2 weeks. But I also tell parents, you absolutely cannot go in, because if they cry for an hour or an hour and a half, and then you go in, what that teaches them is that all they have to do is cry for an hour and a half next time, and you'll come in and get them. And the other thing is you have to set very established wake times and sleep times and nap schedules if age appropriate. So what is time required in bed? I usually have a handout, but since I'm not in person this time, I don't have a handout, but this is the total time required in bed, not asleep, for the various ages. And so, you know, I have on here, shouldn't sleep more than, shouldn't sleep less than, and then also daytime and nighttime sleep for those that are still napping. Usually kiddos get rid of their nap between the ages of 3 and 4 years. We'll talk more about that in a minute. So sleep problems and parents' role in those sleep problems. So bedtime resistance. So this is going to be where parents are really going to set limits and establish clear bedtime rules and consistency. Again, you're going to focus on the positive and not the negative behavior. You're going to ignore those bedtime protests and just calmly let them know that it's time for bed. You're not going to ask them, are you ready for bed? You're going to say, it's time for bed. So it's not a question of whether or not they want to do it. It's something that they're going to do. Like I said before, if you check in on your child, they should be brief. It should be less than 1 minute. It's not a social call. You want them to know that this is not fun time, it's bedtime. You know, reassure them, but enforce those limits. And if they come into your bedroom, you're going to walk them back to their bedroom. And again, briefly, it's not fun. This is not fun time. The other thing that I recommend for parents is gates. And I know some parents are concerned that they'll climb over the gates. You can stack 2 gates up on each other. The other thing is, if you're comfortable, shutting the door is completely okay, which it keeps them safe. They can't get out in the middle of the night if you're not awake, etc. And then for the frequent nighttime awakenings, this is where sleep schedule is going to come in very important. So you're going to look at their required amount of time in bed. So okay, someone 10 years old requires 10 hours of time in bed, right? And so if they're going to bed at 7 and you're wanting them to get out of bed at 6, that's about 1 hour longer than they need. So you want to push their bedtime back. And if you're having trouble getting them to go to bed, oftentimes I tell parents to push the bedtime back to where they're falling asleep, to really consolidate their sleep schedule, to make that pressure to sleep stronger. And what I mean by pressure to sleep is they should be falling asleep within 20 minutes. And during the lighter periods of sleep, they should be, most of us are too tired to get up. And sometimes if their pressure to sleep is not strong enough, they will get up during the lighter periods of sleep. So we want them to be so tired that they just roll over and fall back asleep. So we're going to make sure their pressure to sleep is strong enough for someone who's 10 years old, and then make sure that they're not sleeping at inopportune times. So some of our kiddos nap. And like I said, naps usually go away between 3 to 4 years of age. So that would be the first thing I would get rid of. And then some kids fall asleep on the way to school or on the bus. And that 20 minutes or 30 minutes, or sometimes it's even longer, can make a big difference in their pressure to sleep. So I often have them try to eliminate that by talking with the school bus monitor, or, various activities in the car. So common sleep conundrums. So the crib to bed transition. Usually, I understand this can become a safety risk. Kids often climb out of the crib, and that's when we do the transition. So if they're not able to stay in a crib, they might need to transition to a tented bed. If you're not comfortable with a tented bed, like I said, I would clear out their room and use the gate on the door, and just make sure it's a safe environment, mattress on the floor so they can't hurt themselves. And then naps. Usually children that nap beyond the age of 5 is indicating that they're not getting, their sleep is either inefficient or they're not getting good sleep. So that's something to look at. Children usually get rid of their naps between the ages of 3 to 4. Nighttime feedings, this can be a problem with our infants, on up to toddler age. So I always tell my patients that children can sleep through the night without eating between the age of 4 to 6 months. And so some of them, it's become a behavioral habit to eat. And honestly, if somebody were going to give me a milkshake every time I got up in the middle of the night, I would definitely wake up multiple times per night. So once they hit 4 to 6 months, I would recommend eliminating the nighttime feedings. I understand breastfeeding can be a connection for some parents. So in that case, I usually recommend doing it on your time schedule. So if they wake, once a night on your time schedule. So if you figure that you put them down at 8 and you want to get them up at 4 to feed them in 4 in the morning, but they wake up at 2, I would let them either cry it out or try the checking in method like we talked about. The other thing is pacifier use. So studies show that pacifier use can reduce the risk of SIDS. It's optimal between about 2 months of age and 6 months of age is when it's optimal. Beyond that, it can kind of start causing dental issues. And kids beyond 6 months of age actually can get up in their cribs and typically search for their pacifiers. So I will have some parents who say, oh, we've got 4 or 5 pacifiers in the crib. So what's happening is during those lighter periods of sleep, their pacifier has fallen out and they're getting up and searching for it, which pulls them out of sleep more. And then if they can't find it, it's an issue. So usually I recommend completely eliminating the pacifier after 6 months of age. The other thing is electronics. So the blue light on iPads or phones can decrease your melatonin output, which melatonin is a hormone that you produce in your own brain that helps you fall asleep. But it can also throw off your circadian rhythm, which is the rhythm of your brain that helps you sleep. So I usually recommend no electronics about 2 hours before bed. I recently read a study, a side note from the bedtime portion of it, that showed that parents that give children their phone as a way to suffice them, or if they're throwing a tantrum, stop the tantrum, decreases their ability to self-soothe, and thus decreases their ability to often self-soothe at night. And so it decreases their ability to fall asleep, and it decreases their time in bed, is what the study found. So I know that electronics can sometimes be a lifeline for parents, especially if their kiddos are not sleeping. So usually I'll work on consolidating their sleep schedule first and see if we can get their sleep, them to stay asleep or fall asleep a little easier. And then we work on removing the electronics. And then the next thing is medications. So typically with our patients, we try to optimize their other medications to help, in order to help them sleep before we add a sleep medication. And as I said before, I work, first I deal with, any medical issues, so reflux or constipation, those kind of things. Then I'll move on to sleep schedule and then medications if they've tried sleep schedule and that's been ineffective. The other thing I encourage is that parents remember that every child is different. So we use different medications for different things. So for instance, clonidine, I use that to help kids fall asleep, not help them stay asleep. Typically my first go-to medication for helping them stay asleep in the middle of the night is gabapentin or trazodone. Primary care physicians, typically their first go-to is melatonin. There was a study done on about 150 melatonins, and in those melatonins, they're not FDA monitored or regulated. So in those 150 melatonins, many of them had between 10% and 478% of melatonin that they said that they had in them. So some of them might have none in it and some of them might have more. So I always recommend parents get pharmaceutical grade melatonin, or make sure that the label says pharmaceutical monitoring on it. There's a little yellow stamp that says that on the side of them. Because what happens is if they're not monitored, which means the FDA is checking them occasionally every few months, you might get one bottle 1 month and it'll work really effectively. And the next month you might get a different bottle and it'll have a different dose of melatonin in it. So it might not work as effectively. So then you kind of have this waxing and waning of sleep. So I realize that I moved through my slides pretty quickly. Most of the time I have a lot of questions. So does anybody have any questions?
I'm running to get here for the questions. Go.
I apologize.
One second.
Can
you hear me? Can you hear me, Amanda?
Yep, I can hear you.
Okay, great. Okay, first question. Please explain how constipation affects sleep.
Well, some of our kiddos, when they're constipated, they're just wildly uncomfortable, right? So I guess the best way to put it is if you hadn't pooped for 3 or 4 days, we'd probably be pretty uncomfortable, and they're so uncomfortable that they have difficulty sleeping. And then in addition to that, when they're so backed up, stuff is either going out or it's either up or down, right? So if you're not pooping and it's not going out, it can cause reflux, and then the increased constipation can cause reflux, which causes sleep problems as well. So they're either uncomfortable or it increases the reflux.
Great lead in. Can you suggest any meds to reduce bedtime reflux?
So there's kind of 2 classes here, H2 blockers and proton pump inhibitors. I typically, in our kiddos, I've not had effective use of H2 blockers. So I use a proton pump inhibitor, so Prilosec or Prevacid. So omeprazole is the generic name. So that's typically what I use.
Okay. A couple people asked if you can share the sleep chart. Can we?
I can send that to Marissa. Does that work?
Yeah, you can send it to me and we'll get it out.
Okay.
If your duper snores, there's 2 questions about snoring. So if your duper snores, what would you suggest? Would you suggest a sleep study and then cause and treatment for snoring? So I think that kind of goes together.
So snoring can be either central, which is part of your brain, you have difficulty breathing. We don't see that a lot in our Duke kids. We see that in some of our other syndromes, or kind of obstructive. So I would start with their PCP and check and see if they have big tonsils or big adenoids and go go and see about that first. The next thing is sometimes kiddos will snore when they have allergies. So if they don't have big tonsils or adenoids, I would get a sleep study. But I would also try a little bit of Flonase. What Flonase does is it decreases the inflammation. It's a steroid, it decreases inflammation. And so it can sometimes kind of shrink those things that might be making you snore, blocking your airway passage.
Okay. How do you get independent falling asleep and staying asleep without parent or caregiver laying with them?
Okay, so I'm not sure how old this kiddo is. So that makes a difference. Do you
9.
know?
I was going to say under 10.
Okay, so some parents really don't like the cry it out method, but honestly, that's been very effective. So what you do is you consolidate their sleep schedule, like I talked about, you know, if they're, and then let me start over. Consolidate their sleep schedule, make sure they have a good sleep schedule. And then for the kiddos that won't fall asleep on their own, I usually have parents check in. So what I do is that I will have them put the kiddos to bed, you know, and they go through the routine, put the kiddos in bed, and then they say, oh, mommy's got to go switch out the laundry. And then you come back and you check in on them. And you're going to keep checking in on them every 3 to 5 minutes. Some of our kiddos need it every 1 to 3 minutes, but you want to check in on them until they fall asleep by themselves. If that doesn't work, then it's a little more complicated. Usually I'll have parents do gradual extinction, where they first sleep on like an opposite side of the bed of the child and gradually move themselves out of the room.
How would you adjust that for a kid who maybe when the cried out method, they vomit, like they have acid reflux or they're prone to vomiting when they're upset? How would you adjust that?
That's when I would do, well, first of all, I would treat the acid reflux if that's the issue, and kind of treat, usually kind of the vomiting is an anxiety type thing. So I would also work on that a little bit. But that's when I would do the checking in method and also do the gradual extinction, because the idea is for them to fall asleep by themselves without you there. Because what's happening is you're falling asleep with them in the room, and I'm guessing maybe you're sneaking out. So then when they wake up, they're like, oh gosh, where's mom? Where's dad? And so then they want to come find you. But if they fall asleep without you in the room, that's not the last thing they remember. So typically they'll stay in their room. But again, typically I think consolidating that sleep schedule usually takes care of that, because you want their pressure to sleep to be so strong that during those lighter periods of sleep, they just are too tired to get up and care. They just want to roll over and fall asleep.
There's a duration, there's a couple duration questions in terms of like how much time should a patient be in bed based upon age. So we've got the ages that we've gotten are 16, 19 to 20 and 30-year-olds.
So I'm going to put this up here while we're talking, but so teens and adults, so teens, I usually say they need 9 to 8 hours of sleep, and adults 8 hours of sleep, which I understand in our population, it gets a little difficult when they get older, because, you know, what do you do with them for that time? And, you know, it's more difficult to control kind of the situation when they're older. I understand that.
Okay. I'm going to ask 2 more questions because I can keep going if you're willing to stay here. Lunch is going to be ready.
We're
So
good.
I'm happy to go there, but I'm going to keep asking questions as long as anybody wants me to ask. So how do you feel about sleeping with dogs, as in for helping with sleep? So like therapy dogs and that sort of thing.
So I am a big dog person, a big proponent of dogs. I don't know that I feel that they help with sleep so much. So, you know, if your child's able to sleep with them and stay asleep and it's comforting to them and it decreases their anxiety, go for it. I don't think there's any big literature on sleeping with them. I know I sleep with my dogs, and they often get up and move around a lot in the night. So that might make them wake up. So I think if it's a comfort thing for them, if the dog's not going to stay put all night, maybe keep them on the floor, you know, in a bed on the floor where they can, you know, move around as needed and not wake the kiddo up.
Okay. We have a couple questions about melatonin and dosage of melatonin.
Oh, so dosage depends on age and weight. But I've honestly not had a lot of good luck with melatonin. There are some studies that show that in autistic children, long-acting melatonin is very effective, and helps with them because they excrete it differently than typically developing children do. But dosage wise, I usually start with 1 milligram and then 3, 5. Once you get to 10, that's way too much. The thing about it is that it's a hormone occurring naturally in the body, right? And so our bodies don't even produce 1 milligram to help us go to sleep. So I think in that case, it's more than likely a sleep schedule issue.
Okay. Speaking of that, somebody asked, what do you do when a child wakes up at night?
So I would consolidate their sleep schedule, but that's kind of a loaded question because it depends on why they're waking. So if they're waking because their pressure to sleep's not strong enough, are they waking because of a pacifier? There are many reasons kiddos can wake in the middle of the night. Are they waking up because they want a bottle? Those kinds of things. So it varies based on the situation.
Okay. Does the diagnosis of epilepsy require more daily sleep overall to recover, in your opinion?
I'm glad you asked this question. So kiddos with epilepsy don't require more sleep than a regular kiddo. Now, that being said, when kiddos have seizures, it's very exhausting for their brain. So they might need a little extra nap or time to recover. But overall, if your kid's seizures are well controlled, they should not require extra sleep. They're just like any other kid.
And what about the ones that are not well controlled?
So they're probably I can't say that ultimately like how much sleep they need, but with them, you're going to know, right? Because during a seizure, their neurons are kind of going haywire, right? And so they're just literally exhausted from that. So you'll know they are going to require more sleep, but theirs is going to be more like after their seizures, they're going to need a little bit more time to recover in sleep time.
Okay. What about, Christina, somebody asked a question, screaming at night without actually opening the eyes. Is it a sign of something else going on, or just how all kids struggle with sleep? Christine, if you can clarify if he's sleeping or is he awake screaming? So we'll wait till what? You don't know if he's sleeping? He might be sleeping, but he might not be sleeping. So he's trying to fall asleep. He has his eyes closed, but he's screaming. What do you think about that?
That sounds kind of like a parasomnia. So maybe a night terror is what that sounds like. Usually stuff like that is a sign of poor sleep schedule. So that's usually where I start, is with the sleep schedule, consolidating their sleep. And then for parasomnias, I do have some kiddos that are on medications for that. So those are usually my ones that have bad parasomnias, like getting out of bed and walking and things like that.
Okay. We're going to go to the flip side. What if they sleep too much? So 12 to 13 hours may not be sleeping very well. Do you wake them?
So are they having difficulty at other times sleeping? Because sometimes what you'll see is that like they'll sleep for 12 to 13 hours, but then the next night they won't sleep. So in that case, I would put them on a very strict sleep schedule. They sleep for, the total time that they're required in bed, and wake them and keep them on a sleep schedule. If they are, I don't know how old this kiddo is. So, I have on here, should not sleep more than, should not sleep less than. So, you want it in that range. If they're requiring more than that, then I think you need to look into the health medical stuff, because, when you're sick or have an infection or you're having seizures, they're exhausting. And so you would require more sleep in those instances. Healing requires sleep.
Okay. Mixing GABA and melatonin, is it okay? And can we take it for long term?
Gabapentin and melatonin?
I think, is it gabapentin or is it GABA drugs? If Camilla can hear me, just to clarify. I'm just waiting for her to respond. Well, while we're waiting to see what the GABA is that they're giving them, a child wakes up in the middle of the night hungry because their ADHD meds have worn off. What do you do in this case, a 6-year-old?
Are they not, so that they must not be eating because of their ADHD meds? In that case, I would rearrange their ADHD meds. So sometimes it might mean to have a longer acting ADHD med in order to make it a smoother ride, or in their case, and sometimes I can deal with them not eating issue, or lower dose, or honestly change med if they're not eating, that's a problem. And not eating and not sleeping combined, that's kind of the bedrock of, Maslow's hierarchy. So you want them eating and sleeping. So I would do some med adjustments.
Okay. Clarification, she gives them, it's GABA powder.
GABA powder.
I think it's
I
probably,
don't,
it's probably just one of the over the counter.
yeah, I don't know a lot about the GABA powder. I have had a few patients on it, but I haven't honestly researched that. It's not, since it's over the counter, it's not something I prescribe, so it's not something I typically look into. So I honestly don't know the answer to that question.
We did actually an entire webinar about GABA and the use of GABA drugs for sleep in Duke 15Q. I can actually post that. Shefali Jeste did one for us because we talked about GABAergic. And I can post that if that's of interest. So I'll post that in this as well. Allison, yes, we're gonna get the bedtime chart posted so that everybody can see it. I think we covered all of the questions. Oh, this is the biggest one actually. What is the neurological explanation for why neurodivergent people have so much trouble falling asleep?
I don't know. There's not a lot of answers for that. And like I said, every kid's different, right? So if we got a sleep study on XYZ number of kids, you might see something different in each one of them. But regarding sleep studies and stuff, sometimes they're like, I believe they're slow wave sleep. I could be wrong here. Their slow wave sleep is affected.
Okay. We just got one more in. My son's neurologist medicated with risperidone to my son for prolonged sleep. Is that okay versus melatonin?
Wait, the endocrinologist medicated
the
with?
Neurologist. The neurologist put the kid on risperidone for prolonged sleep. Is that okay versus melatonin?
Well, they're two very different medications. So melatonin is something that occurs naturally in the body, and risperidone is typically used for behavior. So I would use, that wouldn't be my first choice for sleep. And it depends on his sleep issues. So that question requires more information for me to answer, because I only use risperidone for sleep, and I use it sparingly just because it helps behavior sometimes, but it can also have others.
Oh, you froze for just a second.
What part did I freeze on?
You're back. Okay. And the last question, which I think I can answer. Can the lack of sleep, less like sleep, trigger the onset of seizures? And if your kid is prone to epilepsy, yes. Lack of sleep or less sleep can trigger seizures. So
yes.
Thank you so much. And if there's any other questions that need to come in on the app, I will send them to Dr. Amanda and to have her answer them. And I will also post that sleep, the what you're seeing here, and the sheet that was asked for before too.
So the last, hold on, the last question, I feel like sleep and epilepsy are honestly usually kind of a vicious cycle, because epilepsy causes poor sleep, and then this poor sleep causes seizures. So it's kind of this vicious cycle. So we usually try to get both of them kind of under control in order to help each other.
And then medication sometimes has side effects of sleep. So
and that's when I said utilizing medication to your advantage, right? So before starting a sleep medication, honestly, I'll usually maximize their sleep meds, the ones that make them tired, which might mean giving for instance, Onfi. Onfi helps with anxiety and sleep and seizures. So it's kind of a wonderful little miracle drug. And so usually I'll give a higher dose of Onfi at night to help with sleep sometimes if they're having issues with sleep. Or, the other ones that kind of cause you to be more tired, you can do a bigger dose at night, those kinds of things.
Okay. I think that was it. Any other questions? Okay, what's your question? Okay. Okay, the question was their daughter's been prescribed oxygen, and also they've been talking about a CPAP. At what age would you recommend or have seen success with CPAPs?
So wait, you kind of blipped out there. So she's on oxygen and a CPAP. And what was the question?
No CPAP yet, but they are talking about it. So at what age have you seen the CPAP be successful?
So there are a lot of behavioral strategies to help use the CPAP. I think that it's not a question of like what age of CPAP is successful. If they need it, if they're having a CPAP recommended, it's typically because they have some sort of sleep apnea, which the sleep apnea in itself can cause fatigue and a whole other plethora of issues. So honestly, I would focus less on the age for the CPAP and focus on behavioral techniques to help their child keep the CPAP on.
Last question. What is Onfi?
Oh, Onfi is a seizure med. It's an atypical benzodiazepine. So like typical benzodiazepines are Valium and Ativan, Klonopin. They are typical benzodiazepines, meaning you're not meant to be on them long term. Onfi, or clobazam is the generic term, is an atypical benzodiazepine, meaning it's for seizures, but you can be on it long term and it helps with seizures. And Valium and Ativan are similar, but not meant to be on long term, but we use those for rescue medications for seizures.
All right. Thank you so much. This was really, really informative.